Welcome to Frontline, where we are taking a balanced and informed look at ketamine use in this new 4-part podcast series. In part 3, we'll be exploring how we can respond to ketamine and how we can take a harm reduction approach for those who are actively using. According to the Office for National Statistics, ketamine-related deaths in England and Wales have been increasing in recent years. Between 2018 and 2023, the number of deaths where ketamine was mentioned on the death certificate rose from 21 in 2019 to 37 in 2023.
However, it's important to note that despite this increase, ketamine-related deaths remain relatively low when compared to other substances. For instance, in 2023 there were 5,448 deaths related to drug poisoning in England and Wales. Ketamine-related deaths therefore accounted for approximately 0.68% of the total drug poisoning deaths in England and Wales in 2023. The rise in ketamine-related deaths aligns with an increase in its recreational use. In 2023 alone, approximately 299,000 individuals in England and Wales reported using ketamine, the highest number on record.
This is Joe Moore, the registered manager at the Birchwood Kaleidoscope House.
And also there's the people that aren't getting to us, the people that have sadly passed away, who haven't had that support in the community, haven't had the GP awareness. They've attended A&E with their family members, and the GPs, the doctors in the hospitals, haven't had any idea about ketamine. So they're turned away, and that's when it's too late. So we're also working with the parents that have lost their children to set up a family support group to enable people to have somewhere to go where they can gain that support and that information that they need to keep people safe.
So, despite the harms mentioned in previous episodes, most people will not experience the negative effects of ketamine, and taking a harm reduction approach with people that use the drug is key.
Firstly, consider how it feels when you're told what to do. Signs telling us not to do something can stir up a deep rebellious attitude within us. When this happens, we're experiencing a concept known as reactance theory. This is a psychological theory that explains how people react when they perceive their freedom of choice is threatened. The theory suggests that people are motivated to restore their freedom and may do the opposite of what they are pressured to do. If we apply this approach to drug and alcohol use, you can therefore see how people might respond negatively if told not to use or that drugs are bad. So what is harm reduction? At its core, it's a practical, evidence-based approach that focuses on reducing harm rather than punishing drug use. But where did it all begin? It can be traced back as early as the 1920s. Some of the first harm reduction ideas came from public health responses to alcohol, such as during Prohibition in the US, when alcohol was banned for a period of time. The 1950s and 60s saw the first trial of opiate substitute prescribing programs, where methadone was used to help people with their opioid addictions. However, the modern movement truly began in the 1970s and 80s. The Netherlands and the UK led the way, introducing needle exchange programs to reduce the spread of infections. The need for this approach was increased by the HIV/AIDS crisis in the 1980s. This made harm reduction a global necessity to reduce the spread of something that people did not know much about, and could also help to reduce the stigma and shame from those struggling with HIV and AIDS related challenges. The 1990s and 2000s saw harm reduction going global. Countries like Portugal decriminalised drug possession and focused on health-based interventions instead of criminal penalties, leading to fewer overdoses and HIV cases. Harm reduction has now gone beyond drugs. It's used in alcohol policy, mental health services, and even led to the development of e-cigarettes vaping as alternatives to smoking cigarettes. Further approaches seen in the 21st century includes rapid testing strips for newer substances, naloxone distribution for those using opioids, and drug checking services. All of these continue to evolve in response to changing drug trends. Remember, harm reduction is not about enabling drug use. It's about keeping people safe, reducing risks, and offering support without judgment. It's an approach that's saved lives for decades and continues to adapt to new challenges, such as ketamine use. This is Peter Furlong, the National Harm Reduction Lead for Change, Grow, Live.
Some core harm reduction stuff about, try not to mix it with other drugs, especially alcohol or cocaine, depressants and stimulants. It's going to magnify the risks that you're facing anyway. I think the problem with ketamine is if people are just using it on its own, they sort of feel that it's hangover free. So it's giving people education and information that whilst you mightn't feel the next day there's any come down off it, your body is dealing with it very differently. And if it merges from occasional use into more regular use, that's when we've got to sort of give them those key messages out, really. As I said earlier, I think, the majority of drugs, if people use them occasionally, a few times a month, ketamine probably won't be an issue for people. But I think what I'd say to other professionals is trying to understand the way it's changed in its use. Because back in the day, a little bit, when it was a club drug, it didn't really present as that much of an issue because it was occasional use. Whereas now, if people are using it to self-medicate, to chill out, to party with their close group of friends, or just behind closed doors of a night, that's where we've got to think of tailoring our harm reduction advice to meet the use, really. It's going back to the good old-fashioned core advice about, what is it people are using, how they're using it, drug setting.
This is an idea developed by Zimberg in 1984. It's the idea that the effect of a substance isn't just about the drug itself. They're shaped by three key factors: set, setting, and the drug. First, there's set. This is all about the individual, your mindset, your body, your personal history. Things like your mental health, physical health, genetics, how much sleep you've had, what you've eaten that day, any medications you've taken can all influence how ketamine affects you. Even your mood before taking it plays a role. If you're feeling anxious, stressed or down, for example, that can change the experience entirely. Next, there's setting. This is the environment where ketamine is used. Are you with trusted friends? Are you in a risky or unfamiliar place? Are there potential hazards, like open water, busy roads, or lack of access to medical help? And finally, there's the drug itself. This includes what's actually being taken, and there's no guarantees that a person will be taking just ketamine. It also includes how much you use, how potent or pure it is, and how it's consumed. Is it used alongside alcohol, medication, or other substances? Even small changes in these factors can dramatically alter the risks and effects. What's important about this framework is that it reminds us that drug-related harm isn't just about the drug. Two people taking the same substance might have completely different experiences depending on their set, the setting, and the drug itself.
This is Joe Moore, the registered manager at the Birchwood Kaleidoscope House.
I suppose from a harm reduction point of view, it's teaching the service user to not mix their drugs. It's teaching them to be able to crush the powder really finely so that they're not having those complications from an ENT perspective. Never ever go and use a bath or shower after you've used drink or drugs. There's an increase in people passing away due to people having drugs and using a bath. We say use naloxone and testing kits. So go to your drug and alcohol service. If you want to use ketamine, allow it to take effect. Don't use too much, go little and often. Test your drugs. You've got Wedinos, you've got the testing kits from the community services.
Wedinos is a harm reduction project providing an anonymous and free testing service. It also reflects trends in substance use. More information can be found at wedinos.org.
And use where other people are. So don't use the drugs alone. Tell somebody what you're doing that you can confide in and they're aware of where you are at that point in time. And then be aware of the naloxone kit. So we know that these batches can be mixed with all sorts of synthetic opioids. Some might be mixed with heroin, fentanyl, nitazines. And it's about being able to understand the kit. You might have a nasal kit, you might have an IM kit, and be able to use that and read the pamphlets that come with them so that you are aware so you can help somebody else. Teach your family, teach your friends. If you're going to use with somebody else, understand how you can reverse that opioid issue. And it's always better to use it if you're not sure and somebody becomes sedated or unconscious. You need to obviously ring 999, but you also need to start CPR and give that naloxone.
This is Lisa Buckley, the National Lead for Detox and Rehab with CGL.
I think firstly, it's about asking the person what they want, really. And hopefully you've developed that relationship where you're in a place where people feel able to trust, not being afraid to ask a question as well. If you think something's going on or you're struggling to engage with somebody, because that's going to be regardless of who you work for. If somebody's using ketamine and they're chronically incontinent and they're struggling to engage with a housing worker or a mental health worker, again, it's about meeting people where they're at, adding flexibility into your appointments so you can go on a home visit or you can call them rather than expecting them to come and see you, because that might be the first point of contact that then leads into a referral into a drug and alcohol service. So flexibility, openness, and building that trust.
Why is taking a harm reduction approach so important? When it comes to ketamine use, a strict just don't do it approach just doesn't work. In fact, it can sometimes do more harm than good. If professionals or even friends and family dismiss someone's ketamine use or simply tells them to stop, it can create shame and stigma. And when people feel judged, they're less likely to reach out for help, ask questions, or access support. Ignoring or avoiding signs of use doesn't make the risk disappear, it actually increases them. When people feel like they can't talk openly about their drug use, they may be more likely to use in unsafe ways or in isolation, which can lead to greater harms like overdoses or medical complications. The following interviews are from people currently in recovery at the Birchwood at Kaleidoscope House.
To get an understanding of it, understand it's probably not like many other drugs out there, you haven't got a time span like most drugs. It will straight up demolish your body or kill you. And that's instant. Knowing that it's younger people taking it, so it's a different way to talk to them. And just knowing the actual harms of it, because I feel like I was never told the harms. They just treated it because I always hear alcohol and stuff is a death of 1,000 slashes and ket's not. It's a couple stab wounds and you're out of it because the way it damages your bladder, your kidneys, your heart, your whole body, your bowels is I've never heard of a drug like it, to be fair. And same with hospitals. I was going to hospital constantly in all this pain, and they would basically just look down at me like, you're causing this yourself. And it's if I could stop, I would have. And they would tell me there's nothing wrong with me, send me home, give me nothing, give me no advice, and to the point where I just stopped going to hospital. I'd rather take care and know that the pain's going to go for a little bit than someone look down at me, judge me, and then tell me there's nothing wrong with me when I clearly know there is. Because the best people to listen to are the people who have been through this.
Because we're not being seen by specialists, we're not being seen by people that have the knowledge to say right, there's no point in him to keep on suffering like this. If, for example, we need to take your bladder out, or we need to put a bag in, or we need to put a catheter in, it's not nice, it's embarrassing, but it could save your kidneys, it could save your bladder, and just take the pain away, because it's excruciating. And since I've been here, I've been here for 4 months, and 4 of my friends have died through taking ketamine. 2 of them have had a heart attack. 1 of them took an intentional overdose, and 1 of them crashed in the car whilst under the influence of ketamine. So if I just sort of dwell into my mate that overdosed, he overdosed because of the pain. He was in too much pain, and the doctors wouldn't help him. Plus, he was a sort of guy, he sort of liked to power through things and not act like he was in pain. So not a lot of people really knew what he was going through. So if he would have seen a doctor and actually shown the doctor how much pain he was in, maybe he would have got some more help. same with me. I think if I would have just been honest, and just being honest in the fact that like I'm being honest with you, but you're not giving me the help that I need. Maybe I do need to stop, but before I do that, we need to deal with this acute pain that's happening right now. Whether it's to put a catheter in, whether it's to put deal with that, so that the pain can sort of be reduced, so that I don't have to keep on turning to that drug. If you take them to the doctors and the doctor maybe doesn't know what to do or something like that, if it's like one time, two times, I'd say on the third time that you take them, say to them, I need a referral to the hospital. GPs, I think once they know that it's ketamine involved, they should just refer them straight away. There's a ketamine clinic in most hospitals now, if not to specialist urology, places like things like that, because it's that waiting for that referral that does a lot of damage to the body. What they need to do is realize that some of these people on ketamine, it's not that they don't want the help, it's that they are literally dying in their houses for the help. They can't get to you. They're literally wasting away in wherever they are, taking more ketamine for the pain, and then they might get up, but by the time they get to you, they're in that much pain, or they're needing to wee that much, that they're in their heads, they're just like, I'd rather just stay in my house. I must have looked like a stick animal in duvets, just laying in my bed, crying because of the pain.
Speak to your GP. Make sure you speak to your GP straight away. Make sure your GP's got a bit more understanding of what he's actually talking about. If your GP hasn't got the understanding, you need to go to a drug service that's more ketamine. I know there's not a lot of understanding, but you need to be speaking to somebody that knows about what the effects of ketamine is, and what you're doing to your body, and the way that it makes you, how it destroys your body from the inside out, your organs and things like that. Speak to somebody that's got the best professional help you possibly can. If your GP don't know about it, then go to a drug service. If that drug service don't know, then you research it and go further up to somebody, or speak to somebody. Try and go to, enroll in a group that's like a Narcotics Anonymous, and they'll have ketamine users there. But the understanding will come very, very soon, because I think there's going to be a hell of a lot more people that's going to be in the service like this in the next couple of years, because it's just rife. Because I know one thing. If I come out of here and have one little bit, I can't say to myself, oh, I'll just have one little bag and then that'll be it. Because that'll be it, boom, I'll be off again.
This is James Mawhinney, the Senior Social Worker and Strategic Safeguarding Lead for Change Grow Live St Helens.
The most significant thing is the relationship that you build with somebody, and building that relationship based on trust will enable them to access support in a multitude of different ways. So I feel like that's really significant and really important. Working side by side together, like it really, really does need a partnership approach. It can't just be one single agency on their own. You need to be working with our health services, need to work together, our drug and alcohol services, our children's social care. Like, one of the benefits of working in the area that I work in is, we're all linked in. We regularly have our own ketamine partnership meeting. That's really significant in terms of making sure that we're all aware of the same issues, that we're working together, that we're setting up them pathways and processes in the community. So developing your own ketamine partnership will be really significant and really key to, making sure that we provide the best service for our young adults, or our adults using ketamine, or children.
But I think as time's gone on, I think we've learned that partnership working is the way forward, really. And there are experts within their individual fields with the stakeholder partnerships that we can kind of utilise that knowledge and expertise. And I think that works really well, where everybody comes together. Public health campaigns involving the Department of Health. I had an idea the other day, actually, when I'd noticed they were talking about, NICE were talking about the importance of GPs asking questions around gambling harms. It'd be good if we could engage with NICE and look to see whether they could do the same thing with ketamine as well, And I appreciate there's lots of things that GPs need to discuss, includes weight and how much you're drinking, etc. But it's so critical. And what we want to avoid is a generation of people who have got lifelong health issues as a result of their ketamine use, and that's what harm reduction's about as well, isn't it? It's about getting in there early, and if people are going to continue to use, supporting them to reduce the damage, that the drug that they're using, where you can really. So one of the big signs is young people presenting at GP surgeries with repeat urine infections and not asking the question, not saying, are you using ketamine? And this is something that the St. Helens services have worked really closely with GPs in their region, and they've introduced this screening tool. It's the ketamine screening tool, and it will ask various things around signs and symptoms, and it specifically asks around ketamine use. And it's critical, really, that GPs get the training. We've got lots of services that have relationships within shared care, for example. Within one of my own services previously, we used to do training sessions to shared care GPs involved in the scheme. And they're really kind of great opportunities to have those conversations, deliver the training, not just give them the screening tool and say, get on with it. And that would be the same with A&E as well, because people will be turning up at A&E, whether they've passed out and they've ended up in there. If staff aren't aware, they don't know to ask the question, do they? And it's all about kind of education, really. And we've demonstrated with the St. Helens service that it works if you take that approach, deliver the training to the GPs, get that screening tool implemented, and then they've seen an increase in referrals that have come through GPs. And then it really is about that fast track response that's needed as well. It's not hanging about waiting for people to develop catastrophic physical health issues as a result. It's about getting in there early to support people before that happens.
So if you don't know, don't let it just wait to fall in your lap. Go out there and speak to the ketamine users. Go out there and find information. That's what we've done. We haven't been given any of this information other than from us going out there, working hard to find out what's going on, and then spreading the word to others. So if you find something new, tell other people, alert your public health team, tell somebody that there's a mix of fentanyl that's in a batch that's local. You need to let the CDLO officer aware in that local area to say, look, we've got a concern here, inform the police. So we need to make sure that people are communicating effectively, but also it is their duty to find out about these things and look at statistics. So we're looking at our service users and trying to gain information that is helping other professionals. I think that, it's everybody's duty to find out about these drugs and look at their own policies and procedure and make their own guidance on it from an internal perspective. So we didn't have a prescribing guideline. We looked at evidence-based practice. We looked at NICE guidelines, the BMG, we looked at all these things and we formulated a guideline around our prescribing and our regimes. And then we learned from the clients and we saw how the evidence-based practice went. And that's how we got to where we are today.
When I first got here, I was on, I can't remember what it was called, medication for my bladder because I couldn't hold my urine for more than like 10, 15 minutes. And to be fair, it's embarrassing as a 20-year-old. Like, you can't even get in a cab somewhere without asking to pull over to have a piss. Like, it's just, yeah, it's embarrassing.
I ended up back in the hospital, and my mum was then started getting worried, and she realised what I was doing. So she said to me, like, you have to be honest with your doctor. I'm going to go with you, and you have to tell him what exactly you're doing. So I went back. I spoke to him. I told him what was going on, and he just said to me, "Just stop." That was all. That was his only advice that he could give me, was just stop. And I kept saying to my mum, "It's really not as easy as this. I know that you guys might not see a huge difference in me, but psychologically, I'm not the same." this thing, it's like I'm going to sleep thinking about it. I'm waking up thinking about it. I'm doing it when I go to bed. I'm doing it when I wake up. If not, I'm searching straight on my phone to find out who's got it, where it is, how I can get it. Um, and then especially if I'm in pain, I know that going to the hospital in A&E, the only thing that they do is give you maybe a diazepam as a muscle relaxant, some oral morph to calm the pain down, and then they just send you on your way. And then what they say to you is contact your GP in the morning and get him to either refer you to the hospital or give you some more pain medication. But when you do that, your GP doesn't refer you to the hospital because you're on drugs and doesn't really give you anything that will help the pain because they're addictive prescription medications. So the best he can say is take some paracetamol and stop. I'm 28 and I'm in a really, really bad part of my life. It's got a lot better, but I'm still in a huge fight to sort of get my life back into some sort of form of normality. And it's really scary because sort of it just happens overnight. You don't realize it's happening. You sort of just sit there watching yourself waste away. But in your head, you're having the time of your life. You don't care. It's not a worry. It's not a problem. It's not an issue. You can put that. We'll deal with that tomorrow. We'll deal with that tomorrow. We'll deal with that sort of mentality. And then tomorrow comes, and all you care about is picking up again. It got to the point where, luckily, I think I've weed blood once. That was from sort of trying to weed straining too much, but. I mean, I am now in a wheelchair. I can't use the toilet properly. It's got a bit better, but I mean, I was going to the toilet every 15, 20 minutes.
So remember the core messages for anyone taking ketamine. Go very slow, take your time and only redose after the effects are fully withdrawn. You can always add more. Avoid mixing with other substances, including alcohol and medication. Ketamine is very unpredictable, mixing it with anything else can make it much worse. When snorting it, use straws, not rolled up banknotes, and don't share with others to ensure you limit the transmission of viruses. Ketamine slows reflexes and impairs coordination, so minor accidents are common. Encourage people to stay in safe places. Due to its anaesthetic effects, any sign of pain is significantly reduced, so limit hazardous acts. Ketamine severely impairs coordination, so make no attempt to drive or operate machinery. And also it can distort your perception, so stay in one place, away from hazards, and if you are doing simple things like crossing roads, take extra precaution. And finally, remember, if anyone is experiencing any bladder issues, urinary issues, or any abdominal pain, seek medical support immediately. In our final episode, we're going to explore how we can respond to ketamine beyond harm reduction, explore good practice, and consider the wider political debates, such as making it a Class A substance. Thank you. This has been Frontline, a Risk and Resilience production.